debate session is Artificial Intelligence in Medicine, Empowering or Deskilling Doctors. The moderators for this session will be Dr. M. A. Shekar sir, Dr. H. Basavanagowda sir, and Dr. Basavaraj Patil sir.
Shekar, come. Good evening. I'm sure the debatants are ready for a very exciting debate, partially touched upon and dwelt by Dr. Arvinda when he presented his presentation on AI. After that, we will not waste time because we have to have general body meeting here at 7 o'clock. So my request to both the debatants is 10 minutes is given to both of them to present their first presentation, and there will be 2 minutes for rebuttal. Okay? Proud for Karnataka API by subsequently following Premnath in carrying on the editorial work. A very amazing person, very techno-savvy, and his editorial job also is touched by his AI. And with that in mind, he will be talking on AI and that will be opposed by Dr. Swaraj. He will be talking about the de-skilling component of AI incorporation in our clinical practice. Over to Shrikanth Hegde.
Just one thing before that.
For talking on artificial intelligence in medicine, how it will empower us.
Okay. I should tell all of you, he's an amazing nature photographer. And he specializes on birds photos, not lady birds. He has conveniently disappeared. I couldn't see you.
All the members are requested to stay back. Those members of KRSDI, stay back here. After the debate, there will be on general body meeting in this hall. May I take the voting? How many of you feel AI is going to empower the clinicians?
Raise your left hand.
Raise your...
Swaraj, raise your left hand.
No, don't raise both hands. Okay. That is just marginally more than 50%. But let us see how Swaraj can convert this after his debate.
Remain there.
How many think that it will be de-skilling the clinicians?
See, those people neither are for or against.
See,
you are excused.
Quite a few of you neither empower nor think of de-skilling. Let us see. Please go ahead.
Thanks. I would be speaking for the motion, and I would be defending the case that AI is going to empower doctor, and also it's not going to de-skill the medical profession and the doctors. This is the how counter from newborn cell chambers to cell counters, and from Benedict's reagent to CGMS. My question is, did they empower the clinicians or the doctors, or did they de-skill the doctors? Every time a new technology comes, the argument is that it's going to make people lazy, people are going to suffer like that. But ultimately we adopt to technology, and finally we have seen they've empowered us. Now the AI which has come has challenged all these, because it is challenging the core principle of doctors, that is the cognitive abilities. That is where it is touching upon, and that is why the debate. The skill changes with time. Probably 40 years ago, a cardiologist's skill was measured by his ability to detect a cardiac murmur or to detect a valvular lesion on echo. Today, if you ask what is the skill of a cardiologist, it's the cardiologist's ability to do complex interventional procedure is a skill. So skill evolves over time. What is skill today may not be skill tomorrow. So there is nothing like de-skilling. There is always re-skilling or upskilling. How AI can empower doctors? There are 3 areas. I am not going to detail with a shortage of time. The 3 domains where AI empowers doctor. First is in empowering the cognitive abilities of the doctor. Second is temporal empowerment, that is saving the time. Third is systemic empowerment, like making the treatment options democratic, that is accessible to areas which are not accessible to otherwise. Today's medicine is not just clinical signs, symptoms, and auscultation, clinical examination. It is drowned in data. A patient with CGMS records 288 data points in a day and 4,000 data points in 14 days. Add to this other lab reports and other things. There are clinical practice guidelines, there is insurance work, there is documentation, EMR-related work. So how do we navigate the data and make sense out of it? That is where AI comes into picture. Eric Topol says the AI is the stethoscope of the 21st century, because It's not no more a clinical domain, it's a data domain. How data guides us in the treatment, how data guides us in the prognostication of the case. If we just see the data, it is like a fogged windshield of a car. We can't make sense out of it. Whereas AI makes it clearer, like a wiper, so makes clearer out of the available data. How AI scores over humans, or what is the importance of AI? AI is not just for diagnosis. We can detect retinoscopy, fundoscopy, or even atrial fibrillation by ourselves. But things which humans cannot do, like predicting the cardiovascular risk by looking at the fundus, predicting the onset of atrial fibrillation with a sinus rhythm ECG, or predicting the onset of colonic cancer or breast cancer by normal looking, what looks like a normal mammogram or what looks like a normal colonoscopy. This is the area where AI scores over and empowers really the human beings. The another point, we call now as cognitive renaissance by adding AI. A beautiful paper published in the PNAS, that is Proceedings of the National Academy of Science, where they gave about 42,000 clinical vignettes to 3 groups of people. 1, top performing AI program, 2, top performing physicians, and a 3rd, the group of physicians plus AI. So the performance was interesting. The group with human doctors with AI performed the best. They outscored the AI, they outscored the physicians. This is where what we talk about the hybrid intelligence, that is the human intelligence supplemented by the AI. That is where AI scores over, that is where it really empowers us. Once it was thought that AI is going to create jobless radiologists, but today radiologists are the poster boys of AI. There was one interesting study published in Radiology, incidental detection of pulmonary embolism. The time to detect and report decreased from 7,700 minutes to 87 minutes when AI was used in 2 things. 1, in workflow. 2nd, as a diagnostic assistant, second look. So the miss rate of incidental pulmonary embolism decreased from 44% to 2.6%. And the most important is the time dividend. By the hassles of electronic health records, it saves the time. Ambient AI scribes, which listen to the doctor-patient conversation, records it, transcribes it, and enters into EMR. That is where several studies done in University of California and University of Chicago with ambient AI, they have found made patient contact possible and the clinical encounters enjoyable by the patient as well as the doctor. In day-to-day life, I'm a physician in a rural area, in a district place. Standard of care of ADA 2026 is a 300-page document. I want a gist. I ask AI. It gives me a beautiful infographic in 2 minutes. That's what Eric Topol in his book, Deep Medicine, says, that the importance of AI is not in diagnosis. It is in saving time and making doctors utilize their time for being more human. That is, healthcare can become more human with a machine like AI. Now, the systematic improvement like detection of tuberculosis, antenatal ultrasonogram in African countries, detection of diabetic retinopathy in remote areas, AI helps in democratization of care. Now I address the myth of deskilling. That myth of deskilling or cognitive atrophy with AI use comes from the comparison with the airline industry where they thought that the autopilot mode in the airline made the pilot lose their skill. But that is not practically applicable to healthcare because here the AI doesn't take over the complete job of healthcare or the doctor's job. It only, unlike in aviation, autopilot completely takes over the job of pilot for some time at least. Here, it only does a part in diagnosis or in prediction or in patient management. And today's medical education is also aimed at reskilling the students with AI knowledge and also simulation training. You can train hundreds of students with 5,000 clinical scenarios so that they are better enabled. Clinical skills are always essential because they augment the AI output. If you put good clinical output, your AI output would be better. It is not like you put garbage and AI gives you gold. You put gold, it's glittering gold. That is the benefits of AI. And the legal implication. The doctor is ultimately responsible for his work, not the AI. That is why we have to keep guard our clinical skills, and we cannot afford to lose them. And the true realms of medicine like empathy, intuitive skills, always remain with the doctor. So my argument is AI means augmented intelligence, human intelligence along with the, supplemented by the artificial intelligence. It doesn't de-skill the doctor. We are not competitors. AI handles the pattern, AI handles the math, we handle the patient. We handle with empathy, we handle the fear of the patient, concerns of the patient, motivation, and nuance of care. A physician who uses AI will not be unskilled, he will be unstoppable. Many people think involving AI in healthcare makes the doctors like robot. But actually what AI does is, AI takes the robot out of doctor and makes them human. And my concluding slide is a slide from Kambala. It's a traditional sports event in South Canada. You see the board there, that board, wooden board has a sensor. The important of that, once the buffalo crosses that board, the sensor detects and gives a time in 1/100th of a second. This is how technology has made inroads into what is a traditional sport of a rural place. And so this explains why we should adopt technology. In the absence of this technology, what happens if you have seen Kantara movie, first movie, the Kambala scene, you will understand what happens without technology. I rest my case here, and I not put any data right now. I am sure my colleague will bring those things, and I'll join them with the
Thank you. Now, nobody? You must understand, John McCarthy in 1950s gave the name artificial intelligence. At that time, they thought human intelligence is natural. Anything away that artificial. Today, we cannot agree it is artificial. And Dr. Hegde has come out with a concept called as augmented intelligence. Maybe in the next decade or so, it will become autonomous intelligence. So it is commensurate with narrow artificial intelligence, general AI, and super AI. Where are we today? Have we reached general AI? No, we are still in narrow AI. So you can go on debating good and bad and things like that. It doesn't matter. So he has brought out one concept. It should be augmented intelligence for doctors. It is not artificial intelligence.
Well, Shekar, thank you for that comment. All that glitters is not gold. That's what he is going to talk. We invite you to defend your case that AI is going to de-skill the clinicians.
Thank you, sir. Really an honor and a privilege to stand in front of you, all of you, and give a talk given by an earlier speaker. I am here to debate and not to give a talk. My father's name is Shrikanth, and I am not lying. So my sanskara tells me that I should never argue with my father. Sir, how do I go about it now? So, okay. So, how many of us believe in God? Namo Parvati Pate Har Har Mahadev. So, when we believe that there is only one God, if we are giving that responsibility to another entity, another higher entity, wherein from my conscious, I want to put my consciousness into some other consciousness and believe that that is the truth. How are we going to accept it? Okay, I am not going to argue, sir, with all due respect. I am going to put in certain facts. Okay, so safety, primum non nocere. First, do no harm. That is the classical teaching that we have been taught, and all my seniors are here. So patient safety, health equity, clinical accountability. So today I make a diagnosis of diabetic retinopathy. Fundus cameras, fantastic. Diabetic retinopathy. Oh, you just take a photograph, you'll come to know whether it is moderate, severe, whether you should refer to an ophthalmologist or not. Because as a diabetologist, you're not going to do anything if it is a severe PDR. So what is the point? So tomorrow, that algorithm, inverted commas, LLM algorithm tells that the patient has PDR. I send the patient to an ophthalmologist. The ophthalmologist calls me and says, sir, there is no PDR. This is probably mild NPDR, if at all anything. Even that also I will not say, I will not commit. But I will, for the respect that you have sent to me a case, I'll write mild NPDR. So what do we do next? So with whom does the accountability lie? It has to be with the me or with the ophthalmologist. neither of us can put the blame on the fundus camera. So that is where accountability is at its peak, and we should own up the clinical accountability. Medical professionalism are jeopardized by premature AI deployment. The judge, Shekar sir has already said we are in a very, very early stage, whether we are going to accept it at this stage, whether we are going to put it in practice at this stage, I seriously have my doubts. So, what is deskilling? So, let us have a definition. Deskilling is the progressive loss or failure to acquire core clinical skills due to sustained reliance on technology, leading to an inability to perform competently without assistance. So, for all the things, I would need an AI. So, is it not deskilling ourselves? Tomorrow, sir had put up ADA 2026 guidelines. Put it in that whichever chatbot we want, it will give you a conclusion. So, are we not deskilling? We are just putting the data in there, we are wanting something out of it, and we believe that is the gospel truth. How good is that? So, cognitive offloading. Sir, actually, probably we both have made the PPTs from the same AI tool, sorry. Outsourcing, reasoning and recall takes to... No. I'll come to that point. I'll come to that very point because in my future slides I'll come. Cognitive offloading, outsourcing, reasoning and recall tasks to AI results in the atrophy of cortical memory pathways and pattern recognition capabilities essential for independent diagnosis. Automation bias, I don't think so I'll need to speak much about it. The psychological tendency to accept AI. We are in a WhatsApp, we are in a social media where whatever comes to our phones is believed to be truth. Nobody does the fact check. How many of you do the fact check? Riots have happened, killings have happened. I am not equating this to that, but still, just we believe that. So what is a riot? A medical riot. If we believe whatever that is coming out of the bot is true, isn't it not a medical riot? So nobody is getting killed immediately, but what happens over a period of time? So that also we need to assess. So never skilling, a phenomena where trainees bypass the deliberate. I am probably a middle generation where seniors are there and probably some few juniors are there. The quality of clinical examination and clinical skills as such is declining. We need not have to put the blame on AI for that. Already they are deskilling themselves. So should we give them another tool to get deskilled even better? I don't know what to say about that. Tacit knowledge or loss, fewer repetitions in manual exams procedures. I am today here standing because I have read n number of times, probably 10 times, probably 15 times, probably 20 times I have read, and that is when I will make a, so fasting more than 126 is diabetes, post glucose load 200, 75 gram OGTT is more than 200. Why? Because it is entangled in my system, wherein I know that anytime a patient comes, it is going to be diabetes. But I am going to give that responsibility to a third person, or in that case, a system. So every time a patient comes, I'll put the information into the system. So how will I be able to act? So do we have to wait for that? To our corticals system to atrophy to that level and then say, oh no, AI was supposed to be doing good, but over a period of time it has gone bonkers. No, we need not have to wait till that. So cost, the cognitive cost of convenience, the NEGM perspective argues that the current fears about AI descaling are a part of a long lineage of anxiety regarding cognitive offloading from pocket guides. Earlier we used to read big books. Now then came the pocket guides. Now we are reading everything in the phone. So these databases, tools have always shifted what counts for skill. However, AI speed and opacity make the risk of uncritical reliance uniquely high. So how much do we trust? How much do we trust that the flight in which we are going is not going to sink or is not going to crash? So that is, you are leaving everything to another power. Where you already believe in one power, now you want to believe in another power. So there is duality, and in duality we do not exist. Sir, Shekar sir will definitely have a counterpoint to it, but let me go further. Skills atrophy, training design and governance determines whether AI augments competence or slowly erodes it. So routine risk assessments, I think I will not be speaking much about it. We all know that there has to be another power which is supervising and making and taking shots at it. So you just put some information, get some conclusion out of it and make a decision out of it. No, that is not going to be the way forward. So neurological this is very, very important. I said that knowingly that goes against my case, wherein I say we both have probably done it out of the same. This is what has happened with me, wherein I was consistently doing that, taking information, putting into a bot and taking information out and then making decisions. So what had happened is Now over a period of time I realized there is something happening within me which is not supposed to be happening. So that is consistently underperformed at neural, linguistic and behavioral levels. So over a long term, if we are doing the same thing, subconsciously you will end up doing that thing only. So accumulating a deficit in independent problem solving capacity. So I will not know fasting of more than 126. Okay, let me put it in the bot. Okay, I do not have a bot. Internet is not there for that particular day. What next? Okay, I will leave the judgment to the audience. ChatGPT users showed the weakest brain connectivity and significantly reduced activity in areas related to memory, attention and planning compared to the non-AI groups. I was an examiner for an undergraduate 6 months ago. I asked, what is your reference for a particular sign? He said, sir, YouTube. So, we need not, as I said, we need not have to blame the AI. Already somebody else is taking the blame. So, automation risk, validation gaps, garbage in, garbage out, yes. But how do we know that it is like our, you put sona and get aloo? No, you're not going to get it. So, to put sona and get only sona out, it takes cost. It is not free of cost. It takes a lot of effort. It takes a lot of systemic management. So are we there yet? No, we are not. Real world impact, the AI hangover. This is pre-AI exposure, post-AI exposure. People who were depending on AI while they were doing a colonoscopy to identify adenoma, wherein sir said we can identify much better. There was a 6% absolute risk reduction. They were failing to identify after when they were doing the AI. So instead of helping us, it is de-skilling us. So congratulations, you have diabetes, fundoscopy. This is what happened in the NHS, wherein inverted commas developed world. So a healthy young patient received an official NHS letter inviting him to a diabetes eye screening, whereas he was not a diabetic at all. He was in his early 20s. So this records revealed an AI-generated summary that invented a complete medical history, which was fabricated with type 2 diabetes, angina, chest pain, and fictional hospital address. So even the human in loop, which is going to augment ourselves. So human in loop. So what does that mean? So even a fatigued staff who is sitting there, humans are supposed to get fatigued. So a fatigued staff member likely accepted that AI's hallucinated summary without verification, triggering automated downstream protocols. So this small AI hallucination plus light oversight is equal to a big administrative reality. Health city doesn't exist, but the patient panic was real. So immediate benefit is reduced cognitive load, frees the mental sources of complex cases, rapid synthesis of vast data sets, decreases immediate mental fatigue, but it induces neural atrophy over a long period of time. As doctors, as people who are practicing diabetes, we know that it is not about what I treat today, but it is how I treat for the next 5 years or next 10 years and give them a proper output or a proper clinical result wherein I try to prevent the complications. I may not be able to prevent the complication, but I try my level best to prevent the complications. So, over a period of time, this neural atrophy will lead to weaker brain activity, accumulates deeper cognitive debt, loss of independent reasoning pathways. This independent reasoning pathways is what makes us human. So, if that we are leaving it to somebody else, we are doing a great injustice. Treat AI as a consultant and not as a substitute, but already easier said than done. This will itself cause more of damage. So triage by algorithm, same thing. People who are having certain biases, hidden biases within the system can cause certain patients, although they are more actively symptomatic, to be triaged separately. So that itself is a bias. So doctor-patient relationship, already it has eroded to a very deep extent wherein a patient coming into your office is already with preoccupied mindset. So we are giving them another tool to erode that AI doctor trust. So I would not be doing it. Automated scribing and templated decision support reduces the cognitive engagement. It reduces your decision-making process also. You know that you are going to give statin for a diabetic who is having a LDL of more than 120. But if that algorithm says, no, the patient's LDL is 119, don't give. So with that 1 milligram, are you able to trust the decision of the AI to make that decision for you? Definitely not.
Swaraj, you have 1 minute to summarize.
Yes, sir. Conclusions and references. References are on the right-hand side. Deskilling is just not theoretical. Evidence from endoscopy showed that there is 6% decrease in identifying the adenomas. The cognitive psychology suggests continuous AI exposure blunts the unaided performance validation gap. Rapid deployment of AI tools often outpaces religious clinical validation, creating a fertile ground for automation bias and error. Preventable risk with centaur workflows, deliberate practice and robust governance, we can harness of AI's power without sacrificing the human competence. So this is my final slide, well within the time, sir. Spiritual formation, at the last point I'm going to talk first. Prioritize mentorship. Today, Sangram sir is sitting right in front of me. I was in his unit as a postgraduate for 6 months. So if he was not there to mentor, probably I would not have been standing here and doing that. So will I give the role of my mentor to an AI? Definitely not. Thank you, sir.
Nice.
From Shrikanth and then another 2 minutes from you.
Yeah. Thank you, Dr. Swaraj gave a different view. Of course, a debate is always for a debate. He raised few points. One is the burden of proof. The burden of proof and validation. He said many other studies are in silico studies. But today, AI algorithms have to be recognized by FDA. Just like drug and devices, they have to be registered by FDA. Already there are 300 algorithms which are registered under FDA. So that much of validation is already there. They're not just in silico studies. There was last year, there was a beautiful systematic review which reviewed about 86 randomized control trial where AI was used. Out of 86 randomized control trial in that systematic review, that was by Eric Topol and John Ioannidis and others. So 81 other studies showed positive patient outcomes. So we are not in silico mode. We are already entered the stage of randomized control, using AI in the randomized control trials. And the second thing is about automation bias and other things. That is a problem with workflow. That is not the problem with the machine. Any technology or any treatment has few adverse effects as well as when we study pharmacology, we study the effect as well as the side effects. So if it causes hallucination, if we use AI, we should also know that it causes hallucination and we should be able to detect hallucination and to use it judiciously. And we cannot relegate the job of any decision making to AI. I always said that it is augmented intelligence. The doctor remains the pilot, AI remains the co-pilot and the first officer, not the pilot. We are not at the stage where the AI becomes the pilot. That is the second thing. So it's a problem with the workflow, not with the system. And the second, he raised about an interesting question about the Lancet paper, which showed that 6% decrease in deskilling. As of now, that's the only study which has showed, but it's an observational study. The article begins with a statement. The introduction of the article, the authors say, large randomized control trials involving AI in colonoscopy has showed a 8 to 10% increase in the ADR detection rate. So already they have mentioned, then randomized control trial and systematic reviews have shown that there is increased ADR detection, adenoma detection rate, and of course the 6% fall, there are many limitations. The authors list about 10 limitations in that trial. Starting from it's an observational study, it's a small group of 19 endoscopists, the trial period was short, and it was not, there were those doctors, those endoscopists had mean experience of 27 years. 27 years, and they used AI for only 3 months. The AI period was only 3 months, that too not daily, on, off, alternate days. So do we mean to say that a memory, a skill which we have gained over 27 years will be lost in 3 months? So the study is just a statistical noise rather than a real randomized control trial.
Thank you, Shrikanth. 2 minutes for rebuttal. You have one more point? You complete it.
And he mentioned about the NEJM perspective article. In the same issue, there is one more article where AI will guide us from bench to bed. We now move from bench to bedside, but AI can make us move from bedside to bench. So that is also another advantage. We can even detect cases with sudden cardiac death, looking at ECGs and go back to see what they have, any genetic abnormalities.
Reversing the journey to revisit and see.
Yeah, so that is...
Rebuttal from you, just 2 minutes.
Yes, sir. I'll probably take 90 seconds only. Sir, FDA is a body which gives regulatory authority to most of the devices. So any device which is given permission by the FDA, we believe is sacrosanct. So how many FDA approved devices do we use in our clinical practice in India? Do we have a equally FDA regulatory body in a developing country like India, or probably Southeast Asia, or even the Chinese? The studies that come out of India are seen with a very inverted commas questionable outlook. So that FDA approach to have the FDA has cleared, let us accept. I don't think so that is workable in Indian setup. You spoke about the hallucination and workflow and the pilot. Okay, when I am taking the responsibility of making a decision out of the information that I have given to a chatbot, so we both are co-pilot. Neither is that person a pilot, nor am I a co-pilot, or nor am I the pilot, nor that is a co-pilot. We both are co-pilots in that case, because I am feeding it, it is giving back to me. So we both are driving it. So I cannot be trusting another co-pilot which is of questionable authority. That is my second point. And then the studies is just a noise. The study is just not a noise. Greatest of the great diseases have begun with a case report. And that case report has become a case series. That case series has become a randomized control trial, and that is when the decisions have been made for over a longer period of time. Right now, in this age, probably it is still too early to say that, but definitely no. Thank you, sir.
Thank you. I'll request my co-chair to give his summary point, then we will put it for voting.
Okay. Now, ladies and gentlemen, please applaud the emotional, vociferous, and eloquent ownership of the ideas these two have. Very nice. Both of you are very, very eloquent and vociferous about your feelings. I just wrote, listening to these two people, let me read it out for you. AI medicine, empowering or deskilling the doctors is the question, and we were debating about it. The truth is, it can do both.
True.
Whether it empowers or erodes capabilities of a doctor depends on how it is to be designed, deployed, regulated, and taught. You agree? Now, the bottom line is, whether you like it or not, AI has come to stay. It's neither inherently empowering nor inherently deskilling. It's a force multiplier, actually, that's the word that should be used, that can elevate medicine to a new precision-driven, compassionate era of patient care. Only if we consciously preserve the art of medicine while embracing the science of intelligence. This is my moderation.
Thank you, Shekar. We'll phrase the question in a different way. Number one, how many of you believe we clinicians will have to embrace and stay with AI, take its assistance for cutting short the unnecessary waste of time in generating the data, accumulating, and putting into practice? How many of you agree AI is going to stay with us? We need to use it effectively. Now, let me put the other question in favor of Swaraj. He has argued several points, stating that it is going to shed the brain and the thinking process of clinician. So it may lead on to cognitive dysfunction, memory loss, or neuronal atrophy, because when you don't keep using those neurons, they start getting atrophied. That is his argument. Do you believe there will be a necessity of cautious use and careful incorporation or embracement of AI, and it can be harmful to the extent possibly? How many of you agree with that argument? So both are the winners. Okay?
Can I just make a comment, sir?
Yeah, please.
Yeah, debates are always difficult sometimes, so duologue would be a better thing. I think morning Arvind also showed many points favoring both of them actually. Medical riot, I like the terminology. And I feel this, when I was doing rounds with my PGs, ask question, by the time I examine the patient, they have the answer ready. I repeat the question the next day, they don't remember. I think over excess use of this AI will help if we don't go back to books and mentors like what Swaraj was mentioning. And it also started affecting me. Every small thing I was putting in the chat GPT to make the sentence sound better, concise. again, of course, whatever we put into it comes out. In the sense, the data authenticity becomes also very, very important. So both of them have done very, very well.
I agree with you.
After two of you to summarize something is impossible.
No.
Great
It's not a
thought.
question
No
of...
opinion.
Yeah.
But the issue is the father of AI, Dr. Jeffrey, says, please move away from AI.
It is...
See, we are more concentrating on the, I've heard about a boy called Andrew in America who was 17 years old, and he asked the AI, how do I die? Then the AI says, you can hang. Then the boy says, can I bring the rope and keep it on my bed? Because I don't want my parents to see it. Then the AI tells him, what is there? It is your life, it is your decision, it is your thing. So it tells him how to hang himself and die, and he died. And the parents have put millions of dollars for the thing. What I want to say is that there is a lot of psychiatric disturbances in adolescents with this AI. So they should know what to pick up from AI and what not to pick up. So, they are teaching in a wrong way also from the AI. And AI is good for us also because, but ultimately, I don't know from where they are getting data from India, because AI may be the data which is analyzed somewhere else, which is analyzed in India. So is it the truth that ours should be different AI and they should be a different AI?
No,
Because we are looking in a point of only investigations.
Correct.
So thinking process, skill process, I don't know what is the next of data export to other countries from India also.
Like we have a firewall for unnecessary visibility of the source material, there need to be a policy and the process in which these type of questions should never be answered by AI. Such kind of policy and the process has to come in, because these are not the questions that AI should answer at all. It should sense that it is somebody is planning to end the life. It should say, there is no, it's not my domain to answer. So such kind of identified harmful answers from AI can be filtered by putting a proper firewall or a process. I think there has to be a policy. I agree with your concern. But thing is, argument is, whether you like it or not, how the pilots are flying the flights to precision mode to one place to another place is AI-driven autopiloting. So that is an advantage for us. But similarly, there can be harmful effects, like one example you gave. Similarly, there can be a mistaken interpretation till the whole data is 100% validated. 99% validation may not be acceptable, because 1 out of 100, if it is wrong, you are killing 1 out of 100 by the decision. So there has to be caution, but you cannot live without AI. That is the ultimate truth.
Anything new accepted, embraced, there will be always antagonism. Down the road, they become silent. After some time, we accept it.
So since this is an evolving field, I think obviously there is a lot more things that needs to be happening. And AI and ethics is something that is still a very, very gray area. As and more we start using it, I think there will be more and more clarity on this. So one fantastic job by both of you all. Great job, Dr. Shrikanth.
Interestingly, I asked the AI now, how do I